to Empowering Ethical Elders, which is a program of the New York Society for Ethical Culture. And my name is Phyllis Harrison Ross. By profession, I am a psychiatrist. By job description, I'm currently the commissioner for the New York State Commission of Correction. And our responsibility is to regulate and monitor all jails, prisons, and lockups in the state. So as you can probably imagine, I've been really kind of busy. I always like to let everyone know that I am 78, so I'm right here amongst you in terms of being an elder, and I hope an empowered one. The society is a religious and educational institution. We provide all the kinds of services that you get in a church or a synagogue or a mosque, etc., in terms of weddings and so forth. And we have Sunday, what we call a platform, and you're all, of course, invited to come. They're interesting when we talk about interesting topics relative to ethics. And our whole religion is really based upon trying to live an ethical life here while we're still alive. And I want to do that as long as I can. I'm very pleased this evening that we have one of the officers of the society, our secretary, Terry Perlin.
I'll be taking notes if I'm sure.
Oh, I'm real nervous about that too. But the Social Service Board is the social action part of the society. And we have programs for children, little children, babies, all the way up through programs for elders. And we try to be activists in terms of things that really are of importance to our membership, including the environment, including social justice issues, criminal justice issues, etc. This program specifically is geared toward elders, and hopefully we are presenting for you things that will help you live a full and rich and enjoyable life as long as you can live. We are right now in the process of planning our program for 2015, and we would really welcome your suggestions for things that you might want us, topics that you might want us to cover, or things you might want us to do. For example, we're planning on having a fashion show for elders this year, including shoes. You know, what are the good, the comfortable shoes to wear? So it doesn't have to be all very serious, medical stuff at all. Now, the Empowering Ethical Elders program has a coordinator, and that's Rob Hoffman, who is also geriatric care manager and senior exercise specialist. And then it has two co-directors who are social workers, geriatric care managers, and your host this evening is Mark Zilberman. And Mark is going to be, so we see a lot of new faces, so we're going to do that thing, we're going to ask you who you are and why you're here to talk about. So I think without further ado, I'm going to introduce Mark, who will then introduce Rob. No, I'm sorry, it's vice versa. Rob, who will then introduce Mark.
I'm here to loosen you guys up. So we're packed, so it has to be very in your seats with the space we have. So let's do it with the head. Just the chin up and the chin down. Very simple. And then over your right shoulder and over your left shoulder. And then the ear to the shoulder and the ear to the other shoulder. Okay, one more time. And now breathe in when you go up. Breathing in and breathing down. Breathing out, going down. Over the shoulder, breathing in and back, breathing out. Over the other shoulder, breathing in. Same time you can see who's behind you. Ear and back. And breathing in and back. Okay. Hands. Right there. Roll the hands around, loosening up the wrists. Couple of squeezes and stretches. Squeeze and stretch. Play the piano and do the brain thing. Okay, I mean, for some of you who know this is a brain exercise. Opens new pathways in the brain. If you don't know how to do this, there's a moment you can do it without thinking, and then the path is created. So first you have the thumb up. Then you point with your other finger, your pointer to your thumb. And then you change. So that's the trick. And you change. So take this home and practice.
I did, but I lost the pathway apparently.
As long as you get frustrated, you're giggling, you're like, try to figure it out, you're creating new pathways in your brain. Yes.
What is that supposed to do?
Well, that's what I'm saying. It creates new pathways in your brain. You're just learning a new skill. It's a fun thing. You can, and when you know it, you can show up and learn other people how
When
to
you
do
die,
it.
the person with the most pathways wins.
Okay, have a great workshop. And let me introduce you to Mark Silverman, our director.
Yeah.
Mary Ellen. Hi. Sit over there.
One thing I did want to mention, I was holding it and I didn't explain why I was holding it. But we had a wonderful lecture the last time on geriatric dentistry. Dominic, one of our few members, had brought these gum soft picks, which they were talking about at length last time, as being the world's greatest thing for massaging your gums and cleaning your teeth and preventing periodontal disease. So it's, I'll leave it up here on the table so people can look at it. It's GUM and it's called Soft Fix.
Oh, no, I need my Not yet.
I'll just say real quick, I found this product out on Staten Island by a worker in one of the pharmacies. And I've been using it, and I quite honestly, I think it's a miracle how it works, and it's so strong. There's nothing you cannot get between with this product. And it's smooth.
They're like picks, but they're soft.
One night I do it at the end of the night. You might use 2 of these at the most. I just bought 2 packs for $10. It's usually a little bit more, but you'll find it really helps your.
That's terrific.
And there were several dentists here last time and everybody was saying, yeah, that's good, so.
No, actually, I was being flippant because I said I don't need them yet, but actually I was thinking, that's terrific.
You probably do need them.
No, I definitely, thank you, but I do, yes. Good evening, my name is Mark Silverman. I'm one of the 2 co-directors for the EEE program here. I want to get framed right here. We're live tonight. We don't know if anybody's watching, but we're live. And I get to see myself, which is distracting.
Just ignore the screen.
Ignore this screen.
Look at
Ignore
the
the screen.
sound.
This is a terrific turnout. And I think before I go any further, it helps us to know how, something that you found out. So I'm going to just name a few possibilities. Senior, raise your hand. That does that. Okay. Meetup. Okay. Did you get like an email from Constant? That's me. Okay. Anything? So anyone who didn't learn from those sources, I'd really love to know where you might have heard about the program tonight. Right? Okay. Sir?
Ryan.
Okay. Okay, thank you. Okay. I guess we covered it. All right, those 3 sources. Well, it's working. It's working. That's a good feeling. So just to tell you a bit more about the program if you don't already know. So basically the program is 2 presentations every month. Educational presentations. We're now in and they're almost always on the 1st and 3rd Thursday of the month. I say almost, that's why I'd like you, if you're thinking of coming down, that you do absolutely check out, because every now and again, for example, this year in July, was not on the 1st due to 4th of July, and I think it was the 2nd and the 4th. So I hate to see you come down for no purpose. And we have brochures, which have the whole program. For example, the next presentation is on end-stage dementia care, the palliative approach. And after that is going to be holiday joys and grudges, gifting company, isolation, and depression. That covers the gamut, doesn't it? Really? But I think that's a new one for us, and I think that's going to be very good, actually, at this time of year. And we're putting together our program for next year, where our emphasis is hopefully, I expect to be a little more joie de vivre. Let's see how it turns out, but that's the way I would put it.
Complaining seminar?
The complaining, yes? No, how to talk to your doctor?
Talking to your doctor, come around.
This is the complaining seminar. Maybe it's a good. I don't think it's a complaining seminar. All right, and tonight's presentation is how to speak to your doctor. Presenter is David Levin, who's the head of. Sorry, Executive Director of Compassion and Choices of New York, which is an organization that does a lot of advocacy at the, as we say, in the social work macro level, the public level, and in matters of end-of-life care, as well as before the end-of-life care. And I'm not going to say any more. I'm just going to allow Mr. Levin to take the microphone. Would you like me to?
Okay, hang it up.
Yeah.
Hang it up.
All right. I wish I knew how to do this. Oh, I should do that. Thank you. I'll get out of the way.
Thank you, Mark. We have a really nice crowd here this evening. I thank you all for coming. It's a little hot in here, and it's also a little crowded, so I promise to have you out of here by 10 o'clock.
Should we put on AC?
Yes.
Okay, it'll be a little bit noisy, but then you have the microphone. Just throw the switch.
So I'm going to talk with you about a range of issues tonight where I hope that you can get your healthcare wishes respected, that you get healthcare that you want, and treatment that you don't want, that you don't get treatment that you don't want. And if there aren't aggressive interventions that are given to you that you would prefer not to have, which happens so very often to people, particularly near or at the end of their lives. So I just want to tell you a little bit about my background so you can judge me in terms of the perspective that I come from. I consider myself to be a patient advocate and working on health justice issues because I think that what we're talking about this evening are really justice issues in the health field. And I've had a background working on justice issues throughout my whole career. I was a legal services for the poor lawyer for 10 years in Rochester, working on a lot of different issues on behalf of poor people. I was a prisoners' rights lawyer, the executive director of Prisoners Legal Services of New York for 20 years, working on behalf of prisoners. And now for the past 12 years as the executive director of Compassion and Choices of New York, working on behalf of patients. So I guess I don't work for you unless the category starts with a P. Poor people, prisoners, or patients. And I'm so glad that Dr. Phyllis Harrison Ross is here this evening because we worked in the same field for many, many years, and this is the first time that we've actually had a chance to meet. So having said that, I'm going to tell you that I'm going to be somewhat critical of the medical profession this evening. And the reason I'm going to be critical is because I think the medical profession deserves a lot of criticism in some areas that we're going to be talking about. But I want to see if we're on the same page for a second. How many of you expect that you're going to eventually die? I'm not seeing everybody's hand. I know some of you are optimists, and that's fine. But the truth of the matter is, I've done a lot of studying on this issue, and I'm probably an expert in knowing that every one of us doesn't get out of here alive from all the studies that I've seen so far, which means that every person here is going to eventually die. All of our relatives are going to die. And you as patients of doctors, every doctor that you have is going to have you as a patient that's going to die. I don't think doctors sometimes realize that either, because they think that they can keep their patients alive forever. At some point, they may have to realize that that's not, in fact, the case. Okay, so, and how many of you in the room want to have your healthcare wishes respected?
Yeah.
Okay, we're still on the same page. This is great. How many of you in the room have ever suffered from pain?
Right now.
Right now. Okay. Anybody else right now? Okay. So these are some of the things we're going to be talking about. End of life decision making, having wishes respected, and pain management. We're going to talk about a few other things, some of which may have been covered in other lectures. How many of you have been to other lectures here? Okay, some of you. How many of you recall if you were here for Toby Weiss's lecture a few weeks ago? She's from Metropolitan Jewish Hospice. Okay. A number of you. Okay. Because I agree with about 95% of what she had to say. She's a terrific speaker and I think a great colleague and professional. But there are a few things on which I disagree with her, which we're going to talk about. Not many. Okay, so some of you said you've experienced pain, right? It's all of it. We're all going to at some point or another. Unfortunately, as we get older, we're going to experience more pain because of illness or disease, and oftentimes that's going to get worse before it gets better. But we have a serious public health crisis in this country with the under-treatment of pain. We know from reading things in the media that there is a real problem now with prescription drug abuse and people dying of overdoses from prescription drugs. That too is a serious problem. But we have a more serious problem which affects a whole world with respect to the under-treatment of pain. Despite the fact that we know that we can contain about 90–95% of pain, in fact, studies show that up to 50% of dying patients or seriously ill patients do not have their pain well managed. We know from a study that was just done recently at Anderson Cancer Center in Texas, one of the best cancer centers in the world, that about 1/3 of their patients had their pain undertreated. And it was twice as bad for people of color. There was a study done by the National Institute of Medicine, which just came out with a really condemning report called Dying in America regarding end-of-life care, which a number of years ago showed that 26 to 40% of all cancer patients did not have their pain well controlled. So why should this be when, what is the main reason that people go to see their doctor? Because they're in pain. Unless you're going for your annual checkup, most people go to see a doctor because they're in pain. Yet, we have a serious problem with the undertreatment of pain for a number of different reasons. Let me explain a few of them. One is that doctors and nurses have not been well trained in medical school or nursing school when it comes to pain management. That's a simple fact. Only 4% of medical schools in the United States and Canada have required courses in pain management. Only 17% even have elective courses. Do you recall if you had courses in pain management when you were in medical school? Oh no, yeah. That's a typical answer from doctors even today, even though that's beginning to change. So there seems to be somewhat of a disconnect. We have 100 million chronic pain sufferers in this country, and many more millions of people suffering from pain at the end of their lives, or from acute pain for some other reason, and yet doctors are not generally well trained to treat pain.
Don't you have specialists Your sole thing is pain management.
We do have specialists.
Ergo, like my regular physician on something will send me to a specialist. Don't they do the same thing?
Well,
Shouldn't-
oftentimes they
rephrase
don't.
that. Shouldn't they do the same
They
thing?
should do the same thing, but that's another problem. Too often doctors think that I can treat my patient's pain. They don't refer people to pain management specialists. People get referred to specialists all the time. All the allergists, the cardiologist, the oncologist, the gynecologist, the gastroenterologist, all these allergists who specialize in a certain field, the same is true of pain. But most doctors don't refer their patients, even when they don't know how to treat the patient's pain, to pain management specialists. So that's one of the problems. A second problem, or third problem, aside from the fact that doctors have not been well trained in medical school, is they are often fearful of prescribing opioid drugs to their patients. Oxycontin, Vicodin, Percocet, whatever the drug, morphine, whatever the drug might be. And we know that, again, from a lot of studies, including one from the State Medical Society of the state of New York, which revealed that 1/3 of the doctors in this state who were surveyed said that either occasionally or frequently they would prescribe a lesser dose of an opioid drug than was indicated to control their patient's pain. 1/3 of doctors essentially malpracticing, in my view. Even worse, 75% of the doctors in the same survey said that either occasionally or frequently they would prescribe a drug other than an opioid drug for their patient's pain, even when an opioid drug was indicated. So, what does this mean? Well, before I get to that question, there's another reason why we have a problem with the undertreatment of pain. Just let me say that, and then you can ask your question or make your comment. And that is that there is poor communication between patients and doctors. It works both ways. Doctors don't ask all the right questions, all the questions that they should be asking, and patients are often not honest, especially as people get older and they feel, well, I'm just going to have to suffer from my pain, so I don't want to be a complainer. It's not so. Your pain can be controlled regardless of your age, and it should be controlled. And so you've got to be an advocate for yourself when you go to see your doctor and you're in pain. And you can ask your doctor, if these are questions which should be asked your doctor, have you been trained in pain management? And if your doctor says, no, I haven't been, then say, you can ask a further question, will you be able to effectively treat my pain? If the doctor says no to those questions, then you should ask for a referral to a pain management specialist. Secondly, you should ask your doctor, will you prescribe opioid drugs for me if they are necessary to control my pain? And again, if the doctor says no, then say, well, maybe it would be appropriate for you to refer me to a pain management specialist. And you should never be intimidated by your doctors. Easy for me to say, I was always intimidated by doctors. Probably for one reason, my father was one of them. And he was a great doctor. He was a wonderful, compassionate cardiologist in Rochester. My father-in-law, who was also intimidated by, as people are, my father-in-law sometimes was the chief of anesthesiology at New York Hospital for 35 years, an amazing doctor. Both of them were. So I know what it means to be intimidated. But, you had a question first and then Mark. Yeah? Or comment?
I do understand why they wouldn't do it. First of all, we have pain in our bodies to tell us there's something wrong. And there's so many people who are my age and older medicating their pain that, you know, if you have pain because your cartilage is wearing out and you take something for that and rub it on so you don't feel it anymore, and your cartilage keeps going and going and going, what good is it? And if you take something for something and you've got another pain, but that thing's covering the other pain too, then you don't know you have a pain in your arm, which is covering the pain in your back with whatever they gave you. I think pain serves a function. And when we're so into, I want to live long without pain.
Look, it's not easy to do. There's no question. I'm not a clinical person, but but that's why you need someone who knows what they're doing. And there are so many different therapies now, which there weren't 40 years ago when my father was practicing medicine. And we have so many different drugs that can be used. But aside from drugs, there are all these different alternative and complementary therapies. We now know that acupuncture works for pain. When it first came into this country, my father thought it was quackery. He didn't understand how it worked. We have biofeedback and Tai Chi and Pilates and yoga and simple exercises, massage therapy, lots of different things which we know can work either in combination with drugs or by themselves.
But you're not answering the question. It's not about the drugs or the acupuncture or pressure or anything else. It's about the pain. You're saying, well, let's just get rid of it. Well, the pain is a symptom of something else. And
Well,
what we're doing is
oftentimes
putting a Band-Aid on it when it needs to be opened and looked at and treated, not pain away, now I can live. I'm not getting,
Well,
I'm not
you're
understanding
asking,
what the function is to stop the pain. Why do you want to stop my pain? So I can go on and it continue deteriorating, but I feel great about it? I don't
Yes,
understand that.
and you will, that's the problem, that's the reality.
and for most
In
people, it's a
other words,
question.
Yeah, I have osteoarthritis in my knee, which I'd rather not have that pain at all. But the fact of the matter is that's what I have. And it's not going to get better, it's going to get worse. And of course, we can slow it down with things, but it's there. So why do I have to have the pain to tell me that?
It's about quality of life, and most of us want to have the best quality of life possible. So if things can be done to control your pain, then they should be, if that's, unless there's something else which is more important to you in terms of your function. But for a lot of people, pain can really interfere with their day-to-day functioning in many different ways, which really is a serious problem for people, particularly as people age.
Mark, just to address that, I don't think we have an argument here in that certainly if there's pain that can be resolved, I would expect the doctor or medical professionals to pursue that. However, there's plenty of pain which is irresolvable, that just exists, and therefore you're advocating for the administration or the prescribing of medications, the options of medications that will, or modalities that will get rid of the pain. I just wanted to add another confounding factor is the prevalence of addiction addicts out there who are looking for substances.
And we're not talking about, we're talking about people who have legitimate pain, want that pain controlled. And although all these drugs are addictive, a small percentage of people actually become addicted to these drugs when they're using them for the purpose solely to control their pain. But there are doctors who won't even, for example, prescribe morphine for someone who is dying, who might be in hospital because they're afraid their patient might become addicted. Now that's really absurd. And people should get the pain management that they need in order to have their pain controlled. And you folks as patients should be in charge to make sure that you are getting the pain management that you need in order to have your pain effectively controlled. It shouldn't be up to your doctor to make that decision. And if your doctor, and now it's true that when doctors are prescribing different things, whether it's medication and or other therapies, these are experiments. It's really difficult to control pain. I'm not saying that it's easy. It's not whatsoever. But you as patients need to go back and be complainers when something isn't working so that your doctor understands and can prescribe or do something differently. Because sometimes doctors will not tell you, please come back in 2 weeks if this isn't working. You've got to be a strong advocate for yourself when you talk, when you're seeing your doctor, or when your pain isn't being controlled by whatever is first prescribed. Yes, sir.
Excuse me, but I believe she was raising another point that
Yes.
none of you have addressed. Hypothetically, you've got the osteoarthritis in your knee, you're taking the heavy pain meds, so you don't have the pain in your knee. However, you end up with a pain in your shoulder, which was caused not only by what, but you don't feel the pain in your shoulder because the med you were taking for your knee is going to be covering that pain. So you can end up with pain being your body's way of saying something is wrong, being masked in a second location because of the first location that you're getting. And so perhaps not justifying doctors the one to prescribe, but theoretically, you're knocking me out on one thing, there can be something wrong somewhere else, and that's how the mess.
Well, I don't take medication constantly so that I'm not aware that I have also rotator cuffs, both of them were torn and they hurt. And I have sinusitis and that hurts. And I have.
I wasn't saying about
what I'm saying
I was just doing.
Is that I think that you're talking in a perfect world where the pain medication, if you take it, it's going to stop everything. And no pain medication works like that. It's not that good. Yeah.
Just one more thing about pain. A lady up in Vermont has got all kinds of arthritic conditions. And she runs a house with 2 dogs and hikes every day. And she has seen every doctor you can imagine of waiting room. And she takes pain medications. And she knows what the conditions are. And if she didn't have that pain medication, she couldn't function. she couldn't move. And the benefit, and if you don't move, then your body gets out of shape, muscles deteriorate, your head gets whack, and you're not functioning anymore. The pain allows you to function.
Right. Did you all hear what he said?
Yes.
Was that here? That the pain medicine actually helps this person to function, which otherwise you could not do and would be bedridden if it weren't for the pain medicine. Okay, a couple more questions because I want to move on. I have a lot more to talk about this evening. I don't know who's first. If you have your hand up.
I have the opposite experience. I was in a car accident and I serious problems with the back. And even though I was 70 years old, I started with physical therapy for my first time. And the thing that all the time the key was stop if it hurts.
Yeah.
And
Yeah.
that's exactly the opposite. Of taking some medicine, you don't feel it now you do these things which hurt because you're doing something bad.
Right. Okay, I think we should move on because I want to cover. Do I have to 7:30 or so? Okay. So, okay, one last question. Yes,
No, I was just going to say, sometimes you take a medication to stop one thing, and the side effects is worse than this thing that you're
Yes.
taking. You might be better off than this almost dying.
Mhm.
Then take that medication. You may as well just stay as you are if they have nothing else. Because I have one abscess a couple of weeks ago, and it was killing me. The doctor prescribed some kind of medication, and I read it, and it says that it could cause problems, leading with your intestine. Now, your intestine is one of those parts that is in the body. If that's gone, you're gone. It didn't make any sense to me. So I'm wondering, what can you do when the doctor prescribes something like that?
Well, I think you can ask your doctor what is the likelihood of different side effects and how bad can those side effects be, and what would you recommend in terms of taking the medicine or not taking it, and if I do start having some of these side effects, what should I then do? So you can have a discussion with your doctor so that you get an explanation from the doctor as to what he thinks is appropriate
Well,
for
I'm
you
not
to do.
concerned. I'm not concerned.
Okay?
I think we need to move on.
Let's go on. Okay.
In regard to this lady, I'm a lieutenant in the Navy.
Okay.
Captain. So therefore I have the use of the veterans hospital. Now, when I
You have the
give
use of what, I'm
the
sorry?
veterans hospital.
Oh, yes, yes.
So when they give you a prescribed drug, they also give you with probably 4 sheets of information. Does your doctor give information on all the different uses, et cetera, et cetera?
He
If not,
did, but I read from the, when the pharmacist give you.
so I'm saying
I think we need to.
written out.
Okay, let's move on.
Can we, ma'am?
Okay,
Let the speaker speak now.
let's go on.
Let's go on.
Okay, so you all raised your hands, I think, when I asked the question as to whether or not you want to have your healthcare wishes respected, which many people don't, particularly at the end of their lives. How many of you in the room have a healthcare proxy? Okay, about a third of you, maybe. So I want to just talk about this for a few minutes because I'm a little surprised that more of you that are here don't, and how important it is for each of you, to the extent that you have someone that you can appoint that's a trusted person and will be a strong advocate for you, that could be your healthcare agent to make healthcare decisions for you if and when you can't make decisions for yourself. And I want to preface this by saying that 70% of us, approximately, will lose the ability to make healthcare decisions for ourselves at some point during our lives. Now, most of you look like you're 18 or over, am I right? Is anybody under 18 here? Okay, just Mark. So what's important about this, if you want to have your healthcare wishes respected, one of the most important things that you can do is to have discussions, conversations with your loved ones, a close friend or close friends, and then appoint one of them, a trusted person who will be a strong advocate, to be your healthcare agent. And to complete the healthcare proxy form, which is just 2 pages, very simple to complete. You don't need a lawyer, you don't need a notary, you do need 2 witnesses. But the most important thing is to have these discussions so that your loved ones know what kind of treatment options you would want or not want, what your goals of care would be in a variety of different situations, so that if and when you lose the ability to make healthcare decisions for yourself, that person is going to be able to step in and be the voice for you. So let me ask a question. Many of you raised your hand and said you did not have a healthcare proxy. How many of you in the room have relatives? Okay, how many of you have friends? I think just about everybody raised their hand, so which means that probably almost all of you in this room have somebody that you could possibly appoint to be your healthcare agent. Now, why is this important? It's really a gift to yourself, and it's also a gift to your loved ones. And if you do not have a healthcare proxy, and if someone can't express the wishes that you have made with regard to healthcare treatment, you may very well be kept alive in situations where you would no longer want to be kept alive. That's what often and usually happens. Now, you may want to be kept alive forever. You might say, well, because of my religious or other values, I'm willing to suffer, and the doctor should just keep on treating and treating and treating. How many of you feel that way? That you want to be treated? Just one of you. Okay, well, the rest of you then, at some point, would not want to have aggressive or other interventions which might keep you alive, like having a respirator or a feeding tube, especially if you had perhaps dementia and could no longer speak and communicate. So let me give you an example. How many of you in the room have children? And how many of you have 2 children? Okay, a bunch of you. So can I pick on you, sir, since you're raising your hand high? You have 2 children. And do you have a health care?
Yes.
Okay, you have 4 children.
I have 6 children.
You have 6 children. Okay, well, you've been wise then to appoint someone to be your healthcare agent. And do all your children know what your wishes are?
No. I have 1 child and 1 wife.
Oh, 1 child. Okay, I thought you had 2 children.
No.
Okay, well, somebody in the room said they had 2, a bunch of you said they had 2 children. Let's assume now that you are 105 years old, okay? And not too many of you are close to 105 yet. You're 105 years old, you are bedridden, you are incontinent, you had a stroke many years ago, now you have advanced dementia, and you also have come down with pneumonia. And the question is whether or not the doctor should treat your pneumonia with antibiotics. What do you all think? Should the pneumonia be treated?
No.
No? Anybody say yes?
Are you talking about assisted suicide?
No, I'm not talking about that. I'm talking about whether or not the person should be given antibiotics for the pneumonia. They have to.
No, they don't have.
Who has to?
They don't have.
Okay, so he isn't. The answer isn't what anybody said. The answer is what you would have wanted at 105 in this situation. And if you have not communicated your wishes, that is a real problem, because you may well get treated because no one knows what your wishes are. But let's assume that you do have 2 children, or a child and a spouse, or a close or a sibling and a child. And now those 2 people are at odds about what to do with regard to your treatment. One, who's a loving son, let's say, says, Mom has always been a fighter. Okay, she's 105 years old, but let's just keep her going. Let's give her the antibiotics. Your daughter, also a loving daughter, who wants to do what's right for you as well, says, no, Mom has suffered enough. Let's just give her good palliative care, good comfort care, and let her go. Well, if these 2 children don't know what your wishes are, they're going to be at loggerheads. They're going to have a conflict, and this happens all the time. It happens all the time. And these conflicts can last forever. It splits up families. It's so unfortunate, and it's also so unnecessary. So that if you all take the simple step, who haven't done so yet, to complete this healthcare proxy document, simple 2-page document, and talk with your loved ones, all of them that you can get into the room at the same time, or if not separately, and your doctors, and give copies to your loved ones and doctors, then it is a lot more likely that eventually, when you can no longer make these healthcare decisions, that your healthcare decisions that you have made and have communicated to your healthcare agent about and other family members will be respected. Does anybody disagree that this is a bad idea? Okay, let me just, before you, how many of you in the room who said you did not have a healthcare proxy are now going to consider completing one and talking with your loved ones? Okay, a few of you. That's great. Thank you. Do it now. Don't wait. Don't put it off. Now is the time while you're all young and healthy. All of you look like you're young and healthy. Most of you in your 40s or 50s, right?
Everyone should have one because that's what it on the seat.
Exactly. Everybody else has a healthcare proxy document. And when I said before to communicate this with your doctors, don't just give it to your loved ones. When you see your doctor, your primary care doctor, if you have an oncologist, cardiologist, talk with them. Say what you say. You know, I don't want to live forever, frankly, doctor. At some point, if I've lost decision-making capacity and I have to have a feeding tube, I don't want the feeding tube. That wouldn't be my preference. Or if you might try it on a trial basis. But frankly, I don't want to live with a bad quality of life where I'm bedridden and where I have to be living with tubes coming out from my body. That's not the kind of life that I want. That's not the quality of life which has made life worth living for me. If it is, that's fine. Again, it's all about having your wishes respected. But most of you, almost all of you said that you don't want to live forever. You don't want to live suffering at the end of your lives. And so if you don't, then you've got to make sure that your healthcare agent who you appoint and other loved ones know what your healthcare wishes are, as well as your doctors. And don't leave out the doctors. They need to know as well.
Sure, this is my clarifying point from my own. I think that there's a distinction between what the patient has or the healthcare proxy has to approve and what the hospital has to do. For example, they want to do some kind of surgery, they want to do some kind of transplant or something else like that, they have to get the approval from the person. On the other hand, they want to give you an antibiotic, you're telling me they don't automatically just have to do that? Simple routine things, you're telling me they don't have to do without approval?
If it's a simple routine thing,
Ergo an antibiotic.
it has nothing to do with really life-sustaining treatment. That's sort of a different situation.
Well, if I may, pneumonia, giving them an antibiotic.
No, because there you can give the antibiotics if you want for comfort care, but not to cure the pneumonia, possibly. So there can be a difference. That's something which should be discussed, and there's time to discuss this with loved ones. So the healthcare agent should be approached and say, what do you have a discussion with mom, and what did she say about this kind of situation? And it's up to the healthcare agent to make the decision at that point, not the healthcare provider. Unless the healthcare agent is acting or apparently acting in bad faith, then his or her decision is the final decision.
Second point, this has all been interesting, but just one question. The topic for this meeting was, quote, how to communicate with your doctor.
Yeah.
Are we going to?
I think I've been talking about that to some extent. Have you been listening?
Yeah.
Okay, well, this one, I've talked about how to communicate with your doctors on pain. I've talked about healthcare proxy. You need to talk with your doctors about that. You have to explain to your doctors what your goals of care are, what your healthcare, what your treatment goals are, what kinds of treatment you want or not want, just like you do.
Well, to me, that sounds like a what as opposed to a how, but all right.
Okay, well, you have to figure out some of it. I can't give you everything in the short lecture tonight.
Thank you.
If you have a doctor that is you know, if you have a doctor that you speak to your doctor and their philosophy about this is very different from yours, let's say they're devout Catholic or something.
Yeah.
Should you get a different doctor or?
That's a good point. The point that this woman is raising is if your doctor has a different view than you do about what kind of treatment must be provided, and let's say he's a Catholic doctor and wants to and thinks it's necessary for him or her to provide certain treatment, and you disagree with that, and now you still have decision-making capacity. The question is whether or not you should switch doctors, and the answer is that's up to you. You might consider doing that if you think the doctor's terrific, but he or she's not going to abide by your wishes, and that's really important for you to have your wishes complied with. Then you might consider going to a different doctor. Absolutely. Yes, sir.
I first want to say that I'm French, not because it's important that I'm French, but there may be some cultural differences between our two countries. So my question is, my American wife, I married recently, I'm just a little more than 18, She still has kids for her, number two, husband. And one of them was taken to the ER recently on the family doctor's advice. My surprise was that when the kid was at the hospital, he was to be given antibiotics by the hospital staff. And my wife, who was there, called the doctor to ask if he agreed. And I was just thinking, now, when you go to a hospital, don't you trust the hospital staff? I was so perplexed. I would like to know, I hope it has to do with the subject of the talk today, how to speak with the doctor and which doctor and who on the staff.
I think it's always important to find out from the doctor what is being proposed in terms of treatment and interventions, and find out what the risks and benefits of those treatments or interventions are, and what the possible burdens are, and what the likelihood is of, in terms of outcome for the patient. So those are really important things to know before anything is started, unless it's a truly emergency situation where care has to be provided now, where the person is going to die, and the doctors don't know anything differently than, well, we've got to keep this person alive because we have no other information from the patient or family members as to what their wishes are. So absolutely ask questions. People, emergency room staff are extremely busy. They don't have a lot of time to speak with you, but to the extent that you can ask these questions and get comprehensive answers from them, that is a really important thing to do, because in the emergency room they will treat just as they do in the ICU, which is another place where people go near the end of their lives. Too many people die in ICUs who really don't want to if they had a choice of not being there. But a lot of times doctors don't know that because the person doesn't have decision-making capacity. There isn't a healthcare agent, or the healthcare agent has not been contacted. So the doctors are generally going to treat.
And the other aspect is doctors fear lawsuits.
Well, doctors do fear lawsuits, and that is I think it's a legitimate concern, or a concern that they have, not particularly legitimate necessarily, because doctors are there to do what's right for their patients. That's what they should be doing, and that's what their concern should be, not with lawsuits. So let me move on.
I just answer.
Please.
You know, I'm a psychiatrist, so I treat psychiatric patients, but many of them have different kinds of other medical illnesses, and they call me. I don't know anything about the surgery, but they just want to talk to me about it, and talking with me gives them a certain comfort level. So, and what your life was doing is not necessarily unusual at all.
Thank you.
Okay, so yes, the last question before we move on.
If you don't have friends or relatives, anyone else could be appointed as the healthcare agent or anything.
The doctor can't be. Your lawyer probably won't be, because they prefer to stay out of these things. So it's better if you do have a friend, an acquaintance, someone that you've gotten to know somewhat, that you trust, and if they're willing to do this. If they're not, then there are a couple other things I would suggest as alternatives. One is to possibly complete a living will. Now, I'm not a big supporter of living wills, but I do think that they serve a useful purpose, particularly for people who don't have anybody to appoint as their healthcare agent, because they can be seen as evidence of your wishes, even though they're not legally recognizable documents in New York State. But what's in those documents can be considered clear and convincing evidence depending upon what is in those documents. So a living will is a possibility. Another possibility is something else I was going to discuss, and let me discuss it right now, which is called the MOLST document, Medical Orders for Life-Sustaining Treatment. And I had a bunch in a packet that I left in another office. I had a meeting prior to this one, I'm sorry. We had a bunch of MOLST forms. There are some here anyway. Phyllis, you brought some of this. Thank you. So this is a relatively new form which came into existence in New York just in 2008. Too many healthcare professionals don't even know it exists, much less patients. You've probably never heard of it before, unless you came to the talk a few weeks ago where I know it was discussed. So the medical orders for life-sustaining treatment is a document which you as a patient complete with your doctor, providing that your doctor is willing to sign it, where you express your wishes with regard to various life-sustaining treatments. The first page has to do with cardiopulmonary resuscitation. And you can say that you want it or you don't want it. So the first page can act as an out-of-hospital, do not resuscitate order as a substitute for the traditional out-of-hospital, do not resuscitate order in New York City. The second page has a bunch of guidelines. There are treatment guidelines, and there are 3 different checkoff boxes here. There's instructions for intubation and mechanical ventilation. There are 3 instructions here, boxes we check off. There are actually 5 with regard to artificially administered fluids and nutrition. Let me just read those. No feeding tube or trial period of a feeding tube, long-term feeding tube if needed, no IV fluids, a trial period of IV fluids. These are choices that are yours to make in collaboration and talking with your doctor, and as your doctor hopefully is telling you what the benefits and risks are of these various kinds of treatments. But in the end, they're your decisions. You sign this along with your doctor. Now, one of the things I disagree with Toby Weiss about, who spoke here a few weeks ago, is she said this is a document, I believe, this is what I heard, for people who might die within a year. Yes, it is clearly for people who might die within a year when your doctor has come to that conclusion that this patient may not live for more than a year. But it can also be for people who are simply in nursing homes or frail elderly who might live for another 2 or 3 years, and it's a good thing to sign then while one still has decision-making capacity. Now, if one has lost decision-making capacity, let's say it's too late for you to sign this document, if you have a healthcare agent, he or she can sign it, or a healthcare surrogate pursuant to the Family Healthcare Decisions Act, which I'm going to talk about very briefly, another way in which healthcare decisions can be made for people who have not appointed someone to be their healthcare agent. So this is a great document. Why? Because it's a medical order. It can also be signed by anybody who just wants to express their wishes with regard to life-sustaining treatments. You don't have to be within a year of dying. You don't have to be in a nursing home. You may be a person who doesn't have anybody to appoint as a healthcare agent, or you don't want to complete a living will. I think this is a better document than a living will. Why? Because it covers so many things, and it's a medical order signed by your doctor, which is supposed to go with you from healthcare facility to healthcare facility, et cetera. So this is a really good document, and it's been shown by studies that where people have completed these documents, their healthcare wishes are more likely to be respected than for people who have not completed these documents, in nursing homes particularly. So, yes, Mark.
Does it supersede a healthcare proxy?
No, it does not supersede a healthcare proxy. The healthcare agent still has authority to make decisions for you, but there shouldn't be a conflict. In fact, at a time when one is completing this with their doctor, it would be a good idea to have their healthcare agent present at that meeting so that everybody is on the same page. Now, the doctor could presumably say, if this document is completed after the healthcare agent is appointed, well, this conflicts with what you're saying, healthcare agent, and this was completed at a time after you were appointed as the healthcare agent, so I think we should take this to the ethics committee and let's have a discussion about what so-and-so's wishes are at this point and whether or not this document, the wishes expressed should prevail.
The last one is the one.
It's not necessarily the last one, but this might provide evidence that you've changed your mind from what you told your healthcare agent 5 years ago, especially if you haven't had discussions with your healthcare agent recently, which is another thing. You should continue to have discussions with your healthcare agent because, frankly, some of us do change our minds about what treatments we would want or not want as we get older. And near the end of life, some of us find life more precious. And we say, you know, I can endure this suffering. I can really take this. I have the feeding tube. That's okay. Others of us will say, we thought we could endure a lot of suffering. Like, this is too much. I can no longer go on living. I don't want a respirator, or please remove the respirator. So let me just say something about healthcare decision-making in this regard, with regard to life-sustaining treatments or any treatments. These decisions are yours as the patient, not the doctor's. Doctors can recommend things, and they should, and they should also tell you what the risks and benefits are of those various treatments, but it's your decision in the end. You can say no to any treatment at any time that's offered to you, and you don't have to be terminally ill. This is while you're relatively healthy. You say, I don't want this treatment. Remember, what was his name, the guy that was Superman, Christopher Reeve?
Yes.
Well, he was on a respirator for a while. He wasn't terminally ill, but he needed the respirator to breathe. At some point in time, he could have said, you know, I'm a quad, I'm in a wheelchair, my quality of life is terrible, I've tried this for a few months, I don't want the respirator anymore. Please remove the respirator. That would have been his choice. It is your choice at any time, and although it's difficult to withdraw treatment once it's started, certainly difficult for healthcare professionals, emotionally and psychologically, ethically, and morally, withdrawing treatment is exactly the same as never starting the treatment to begin with. Again, your decision, not your healthcare providers, although listen to what your healthcare provider says, and hopefully you'll come to an agreement as to what the best course of action is. And if you don't, again, your decision. Too many doctors will say, this is what needs to be done. Well, you might say, this is what needs to be done for some patients, but not for this patient, not for me. Okay? Now, I was going to say one other thing about decision making. If you do, let me just ask one thing
I'm
about.
sitting here getting more frustrated.
Let
I
me
don't
finish.
want to hear
Let me
about
finish.
process.
Let me finish.
I want to know
I'm not
how
talking
to
about
change doctors.
How to change doctors?
How to change.
Okay, so let me talk about just one more thing about healthcare decision making. If you do not have someone to appoint as a healthcare agent, your doctor doesn't want to sign this document, you might or may not have a living will. Under a new New York State law called the Family Healthcare Decisions Act, which went into effect in 2010, loved ones, family members, starting with a spouse, an adult child, a parent, siblings can make healthcare decisions for you, but it's really a last resort option. Why? Because it's probable that you've never had discussions with these loved ones about your wishes. So they're going to be really shooting in the dark. They're going to say, well, they're going to be making decisions in your best interests, but that's about as best they can do, right? So that is why it's so important if you can appoint a healthcare agent to do so. If not, the Family Healthcare Decisions Act can come into play if there is a close relative or a friend who is available to make these healthcare decisions for you. But again, it's a last resort kind of thing, number one. And number two, their decisions regarding life-sustaining treatment are very difficult to make in many circumstances, particularly if you're in a nursing home, and particularly with regard to withdrawing life-sustaining treatment. Don't rely on the Family Healthcare Decisions Act. It's not something that you want to have to rely on. Okay, so let's move on to talk about Palliative Care Information Act. Has anybody ever heard of that? If you become terminally ill, your attending healthcare practitioner, a doctor or a nurse practitioner, makes a determination that you are likely to die with a reasonable degree of certainty within the next 6 months, then that healthcare practitioner must offer to provide you with information and counseling on your palliative care and end-of-life options. Okay? Everybody understand that? Yep. Now, you would think that this is something which doctors are already doing. To a very large extent, they're not doing this. Why? Because they've never been trained in this field. They've never been trained in communication skills. They've never been trained in palliative care, end-of-life care. They are human beings. They're uncomfortable having these conversations. So that's why we have this law in New York called the Palliative Care Information Act. I initiated this law, and I was disappointed to hear Toby Weiss be somewhat critical of it. She said the healthcare professionals were not involved in the process of having this law enacted, and to a large extent they weren't. But you know what? The State Medical Society opposed this law. They opposed this law because it was a mandate on their physicians and because they claimed it interfered with the doctor-patient relationship. Well, how does it interfere with the doctor-patient relationship when the doctor as an ethical as well as a legal obligation under New York state law, before this law actually, to provide information and counseling to their patients about their diagnosis, prognosis, alternative treatment options, and the risks and benefits of those options. How does that interfere with the doctor-patient relationship? It is just telling doctors to do what they're already required to do and making sure that it's a law. Now, Toby said something else. She said that doctors can be fined under this law if they don't comply with it. Yes, they can be fined. They can be fined under any law, under the public health law, if they don't comply. No doctor, as far as I know, has been penalized for failure to comply with this law, and yet I know that many, if not most doctors, are in fact in non-compliance with the law. This is something that you may have to talk with your doctor about. If you know that you or a loved one has a terminal illness and you think that you're really, really sick, ask your doctor. Say, Doc, if you want to know. If you don't want to know, that's fine. If you want to know, say, doctor, what's going on with me? You haven't really explained. You keep on treating me. You keep on saying another round of chemotherapy. But it doesn't say, I'm getting weaker and more frail, and I'm having these side effects, and I am not a happy camper. So can you please tell me what's going on? And if your doctor doesn't tell you, that's a violation of the law. But the doctor can refer you to somebody else who will provide you with this information and counseling. So your doctor should do this in the first instance if he or she has made a determination that you are terminally ill and likely to die within 6 months. Palliative Care Information Act, a very important law. I think we had copies made for everybody tonight, at least a summary of it. Yeah. Okay, so you should all, I don't know if enough copies were made, but I hope all of you have that. Really important. There's another law which is even broader and comes into effect sooner, called the Palliative Care Access Act. Now, I haven't defined palliative care, which I should have done. Does anybody know what palliative care is, aside from Dr. Perlin, Dr. Harrison Austin? Yes, ma'am.
Well, it's when you're given care not to unnaturally sustain life, but to make you as comfortable and pain-free as possible. And basically let nature follow its course otherwise.
That's essentially what it's to give people comfort care, any kind of care to treat whatever symptoms a person may have to improve their quality of life, as well as other things that may be involved in order to ensure that the person's and their family members' quality of life is as good as possible. So we're talking about treating pain. It can be treating diarrhea or nausea. It can be treating breathlessness. It can also be used to treat anxiety or depression. And it's usually an interdisciplinary team that's involved in providing palliative care. A doctor, nurse or nurse practitioner, social worker, chaplain, all kinds of different therapists that might be involved in the patient's care. These are things which ordinarily are not provided to most patients. Even a patient can benefit from this care. So there's this new law that was passed in 2011, which the State Medical Society did not object to for whatever reason. And this law actually requires hospitals and nursing homes to have policies and procedures in place so that patients with advanced life-limiting illnesses who might benefit are going to be provided with this palliative care, which significantly benefits people and really helps to improve their quality of life. Again, something to ask your doctor about if and when you're in the hospital or loved ones in the hospital with a serious illness. Has palliative care been offered? If not, why not? When you know that your loved one or you are suffering from symptoms or from anxiety, depression, or from spiritual issues which might be helped by a chaplain, or psychosocial issues which might be helped by a social worker. This is really important for people, and I can tell you that this is not, it's a new field, and so doctors, for the most part, have not been trained in it. It's a subspecialty now. And part of my concern about doctors that treat patients is this. There was a doctor, a wonderful public health doctor at New York Hospital. He also taught at NYU and Mount Sinai. His name's Eric Cassell. And he said 30 2 years ago now, I believe, in an article. The relief of suffering is a high priority for patients, but it does not appear to be a high priority for the medical profession. And I said, wow, that's really interesting. How can that possibly be? And I wrote to Dr. Cassell because I was giving a talk 3 years ago at the Albany Medical Center. I said, what is your thinking today? He said, my thinking has not changed. And then, consistent with what he said, doctors don't think the relief of suffering is a priority, which it ought to be, of course, because that's to a large extent what we're talking about this evening, aside from making sure that you are able to make informed decisions and have your decisions respected. There was a letter to the editor following an article about some person who got married in the ICU right before they died. And this doctor said, he's a radiologist at Mass General in Boston, he said, doctors get into medical school not because they are compassionate or caring people, but because they have good grades. And I found that kind of think that one of the priorities would be during the interview or some other process that you would determine whether or not someone who's going into the practice of medicine would be a compassionate person, one who would care about their patients and the relief of their patients' suffering. Okay, Palliative Care Access Act, Palliative Care Information Act. Any questions? Okay, I'm going to talk about a couple other things really briefly. One is that at the end of your life, you're going to have some options. You can continue with treatment if you have decision-making capacity, or at some point you can say, no more, I've had enough. My quality of life is so diminished, I just can't go on living as much as I would like to, and I know that I'm not. Two things which I think should be offered under the Palliative Care Information Act in certain circumstances, which probably never are options which can hasten a person's death. One is voluntarily stopping eating and drinking. This is an option which some people will use to have a dignified, peaceful death. We can't be sure, but there was a study done in 2003, reported in the New England Journal of Medicine, with 100 hospice nurses who said on a scale of 1 to 9, they gave their patients quality of death rating an 8, meaning that by their observations, the patients had a good death. Voluntarily stopping eating and drinking is a choice which you can make if other options aren't available, or if you prefer that option. You usually go into a coma within several days and die within 10 to 14 days. Another option
How
is
do they rate it? How do those nurses rate it? How do those nurses rate that?
an 8 out of 9. They were given a scale of 1 to 9. I don't know why it wasn't 1 to 10. It was 1 to 9. A second option, I mentioned that the vast majority of pain can be controlled, 90 to 95%. Some pain can't be controlled. Some symptoms can't be controlled. And so when those symptoms can't be controlled by any legitimate means, by anything that a doctor could possibly do, then palliative sedation is another viable option, an option which is accepted by the American Medical Association, but rarely used, underutilized, I think, by a very large extent for people who are seriously suffering at the end of their lives. And this is an option where life-sustaining treatment is withdrawn, people are sedated, usually to unconsciousness, until the time that they die, they can be brought out of unconsciousness, and they have a much more peaceful, dignified death than they otherwise would have if they had to continue to suffer until such time as they die. Palliative sedation. And the last option that I'm going to talk about is aid and dying. Sounds good. Aid and dying, which some of you may have been reading about. Have any of you been reading about this Brittany Maynard case, this young 29-year-old woman? Have you heard about that? Some of you are shaking your heads.
Kevorkian.
No, this isn't Kevorkian. This is a woman who lived in California. She got a terminal diagnosis, moved to Oregon, and is planning to end her life with prescribed medicines. And this is what aid and dying entails. It's doctors who prescribe, at the request of their patients, life-ending medicines which the patient, who is mentally competent, can decide to take or not take whenever he or she wants. in order to achieve a peaceful, dignified death. And usually the drugs work within a few minutes. The person becomes unconscious and dies within 5 to 10 minutes, can last a half hour. If independent, some drugs will take somewhat longer, can take up to a day or so. They've had the law like this, death with dignity law in Oregon for 17 years, in Washington for 5 years. It's worked just as intended. Very few people take advantage of the law, and yet it brings great comfort to people to know that they have this option available to them. There have been no abuses, there are no vulnerable populations whatsoever according to studies. There have been no problems whatsoever that have arisen despite the many concerns and objections that were raised by opponents. This isn't something which all doctors favor, and they shouldn't have to if they're opposed for whatever reason, but no one should be denied this option if they want to choose it for themselves. It's an option which we think should be enacted in New York by litigation possibly, or legislation, very unlikely. It's only in 5 states right now. In New Mexico, there's a court case that is on appeal after a favorable decision. The 5 states are Oregon, Washington, which were done by ballot initiative, in Montana by a state Supreme Court decision interpreting their own statute, in Vermont by legislation. And I should say something about the legislation. It's so difficult to get passed legislatively because this is, unfortunately, a political issue. Almost all Democrats vote for this kind of a law. Almost all Republicans vote against it, even though the statistics show that in Oregon, for example, it is the people who take advantage of the law are almost evenly divided between Democrats, Republicans, and independents. So it's really shameful, in my view, that so many people oppose this law for political reasons which aren't viable to a very large extent. The Catholic Church is opposed to this, as you might expect. The Orthodox Jews are opposed to it, even though there was an Orthodox Jewish doctor who was on our national board for several years who was supportive of David Muller, who's at Mount Sinai Medical Center, which, by the way, I think has the best palliative care program in the city. There are other palliative care programs, but they're not nearly as large as the one at Mount Sinai. Pardon? Oh, I'm sorry. In New Mexico, there's a lower court decision which is now on appeal. I will bet pretty good money that that appeal is going to be ultimately successful for our side. And I really do think that ultimately this will be the law of the land. But it's going to take some time. It's going to take some time to improve end-of-life care. I mentioned this Dying in America report that just came out from the Institute of Medicine after about a year and a half of study. 500-page report which really condemns the healthcare profession for how it provides end-of-life care to people who are dying. There are so many improvements which are really necessary and essential for people to get good quality healthcare and to get the healthcare that they want and not get healthcare that they don't want. So I'm going to stop here and leave it open for any other questions that people might have. Thank you.
What do you think of the Hemlock Society?
The question is, what do I think of the Hemlock Society? The Hemlock Society really doesn't exist. It was merged within Compassion and Dying a number of years ago. They're a merged organization now. We're now called Compassion and Choices. And the organization does work to improve care and expand choice at the end of life. And so that's what we're about, trying to make sure that everyone has choices which they should have in order to end their lives in a dignified way, in a manner that they want to end their lives, and with the best possible palliative care, if that's what they want, or hospice care. We didn't talk about hospice, but of course, hospice is the gold standard for wonderful, high-quality end-of-life care. It's a subset of palliative care that, again, consists of highly trained, well-qualified doctors, nurses, social workers, chaplains. Everybody, I think, should die in hospice. And guess what? New York ranks 49th out of the 50 states in the number of people who died in hospice at the end of their lives. So your doctor may not recommend to you hospice even though you are eligible and you might die within 6 months. You may need to bring this up with your doctor. Say, doctor, you told me that I'm terminally ill and I'm dying. Why haven't you recommended hospice to me? Are you going to refer me to a hospice or not? And if they don't, then you can try to get a hospice referral and get assessed by the hospice itself to determine whether or not you're eligible. We rank 49th out of 50 states, and it's deplorable. There are many different reasons, but I'm sure that one of the reasons is because doctors do not refer their patients at all, or certainly not in a timely fashion, with 2/3 of patients who are referred to hospice, although they're eligible within 6 months of dying, are referred in their last month before they die, and 1/3 actually die within a week or so after they've been referred to hospice. They're not going to get much of a benefit from just a week. And it's covered by Medicare. It's a lot less expensive than being in a hospital. Some nursing homes now provide hospice care. There's beds at Bellevue Hospital. I think they have 28 beds there. Calvary is like a in-hospital hospice. It's a really good place to go. Mount Sinai, as I said earlier, is a wonderful palliative care hospice type program. So there are lots of different options for hospice. Think hospice if you or a loved one is at the end of their life. Don't think your doctor's going to recommend it. You're going to have to talk. You may well have to talk with your doctor about it.
Why doesn't the doctor?
I think there are different reasons. Some doctors think they're going to lose their patients. Some doctors are afraid that their patients are going to die, and they feel that they're going to be a failure if and when their patients die. They're not failures. Patients are going to die. At some point, their disease trajectory just overtakes them. There's nothing more they can do in terms of curative care, and they have a hard time transitioning to palliative care, to recommending and referring their patients to palliative care or to hospice care. And so they keep their patients. Sometimes it may have to do with monetary reasons, which has been suggested to me by a researcher from Dartmouth on this very issue. He said, I think some doctors just want to continue to make money off their patients. Yes, Mark?
Yeah, I wonder though, are you not concerned for a dynamic to develop where the opposite problem becomes the issue? And I'm thinking of an analogy in this mental health field where we have a long tradition of therapy, but over time, I believe, and I think it's supported, economic forces have moved towards a pharmacological approach and less of the psychotherapeutic. So similarly, possibly develop a dynamic where we move towards, for economic reasons, towards